Welcome to Hesitancy, Equity, and Transparency, rolling out the COVID-19 vaccine. My name is Merlene Tucker, and I'm here with my colleague, Jeff Bornstein. Together, we'll be running this Dialogue for Health web forum. Thank you to our partners for today's event, the Public Health Institute and Impact International, an affiliate of the American Institutes for Research. Now, I'd like to hand over the mic to today's moderator, Dr. Mary Pittman, the President and CEO of the Public Health Institute. Welcome, Mary.
Thank you very much, Merlene, and welcome everyone to today's event, which was made possible by the collaboration between the Public Health Institute and Impact, which is an affiliate of the American Institute for Research. We're excited to have everyone join us for today's discussion on a topic that I know is top of mind of many people. Today, PHI and Impact are presenting the third web forum in our series, Equity and COVID-19, Bridging the Gap Between Public Health and Policy. The series is a continuation of work that PHI and Impact have been doing to try to connect the research, the policy, and the practice to be able to address factors that are exacerbating COVID's inequities. So throughout today's forum and this series, we aim to share actionable interventions to highlight partnerships across sectors, including private, nonprofit, and public and academic institutions. On the screen, you'll see examples of past events, which can be found on the Impact and Dialogue for Health websites. So the goals for today's discussion on COVID-19 vaccine hesitancy, equity, and transparency are to understand the strategies for building trust and confidence in communities for the COVID-19 vaccine. Second, to identify barriers that impact equitable COVID-19 vaccine access and actionable approaches to overcoming those barriers. It's to understand the link between data collection and equitable resource allocation. And then fourth, to learn how to better prepare for future pandemics or public health emergencies. So building trust and trustworthiness is a significant part of achieving equitable distribution of COVID-19 vaccines. While policymakers and health providers, pharmacies, and community-based organizations are working hard to try to build trust, the World Health Organization has defined vaccine hesitancy as a delay in acceptance or refusal of vaccines despite availability. It's important for community leaders, healthcare providers, policymakers, and others to recognize the barriers to vaccine acceptance. COVID-19 vaccine hesitancy can be the result of many factors. And in fact, some people don't even like to use the term vaccine hesitancy, and we'll talk more about that throughout our discussion today. But some of the factors that make acceptance and confidence in vaccines include a history of systemic racism and mistreatment by the healthcare system or governmental entities, mistrust of the current political system and feeling like the vaccine is being required by the government, especially when it comes to conversations about a vaccine passport, misinformation about the side effects of the vaccine and vaccine quality, given the quick time frame in which the vaccine was developed and approved. And to address these barriers to vaccination acceptance, community leaders and healthcare providers are encouraged to invite dialogue by addressing questions and concerns people have about the vaccine at being transparent, and that the information about the vaccine is still a moving target. We have healthcare decisions that are personal, and a two-way dialogue between an individual and their family, an individual and their healthcare provider can help people feel more confident and more open to getting vaccinated. Another way to build trust and trustworthiness in the COVID-19 vaccine is to engage trusted messengers in the community who can deliver the evidence-based information about the vaccine and who can encourage and engage in those very personal conversations that people are having. This approach can help reduce misinformation and promote a culturally responsive vaccine strategy. In addition to building vaccine confidence, the COVID vaccination strategy has focused greatly on equity. The strategies on this slide show that some of the key factors in ensuring equitable rollout and acceptance are applicable at the federal, the state, and local levels. And not just government, but that also includes other organizations at those levels who can help serve as messengers and trusted sources of information. First, clear and transparent messaging is critical to building trust and increasing the number of people who are willing to take the vaccine. Next, to ensure availability, vaccines should be made available in locations that are easily accessible and acceptable, such as local pharmacies, community health centers. And we know that 90% of Americans live within 5 miles of a pharmacy. So making vaccines available at these locations will greatly increase availability. However, there still will be gaps. There still will be places where people don't live within easy access, and we'll be talking more about that. Regarding vaccine supply, policymakers should prioritize supplies that could cause bottlenecks, and to ensure the sufficient supply of vaccine, we really need to have very clear supply chains and the flexibility to get the supply where it needs to be. These actions should be coupled with making sure there are enough trained vaccinators to distribute doses of the vaccine. Finally, data should be gathered and used by local organizations and policymakers to identify where the vaccine is needed the most, target the resources to vulnerable populations, and make sure that it's communicated clearly that the vaccine is available. The CDC has collected data on COVID-19 vaccination rates by race and ethnicity. As of this Monday, they reported that race ethnicity data was known for just over 55% of the people who had received at least one dose of the COVID-19 vaccine. Data gaps make it harder to have a complete picture of who is being vaccinated and how vaccination rates can vary over different population groups. For example, data may not be updated frequently and may not include information on all racial and ethnic and other specific groups, including those with disabilities. And frequently, the data does not specifically detail out some groups that may not be identified through the race and ethnicity data, but are important populations that we're reaching. The data that are available show that disparities exist in the current rollout of the COVID-19 vaccine, and more work needs to be done to reach minority populations. Making vaccination data publicly available should be another priority going forward. It will allow the public health officials to have a better insight into whether disparities are widening or narrowing, and how these patterns may vary across states and localities. It will also help community-based organizations, community advocates, and other community leaders know where they need to be placing their emphasis as well. Next slide. In California, where the Public Health Institute is based, we've implemented a vaccine equity metric, which is based on the success of the Blueprint Health Equity Metric. This metric was developed in early March to address disparities in vaccine coverage, and it was developed based on the Healthy Places Index, which was designed and developed by the Southern California Public Health Alliance. That blueprint and the HPI data shows by quartile the different levels of vaccine coverage. The bar chart on the left shows the distribution of vaccine doses by HPI quartile in mid-January. There's a stark difference in that chart between people living in the most disadvantaged communities in the state, indicated by the dark green, and those who are receiving more than double the rate of the vaccine for those who are living in communities of higher wealth, and those in the communities with the least healthy conditions indicated by the dark blue. With the introduction of the vaccine equity metric, the state began allocating 40% of its vaccine doses to communities in the lowest HPI quartile, providing more than 2 million additional vaccines. By late March, you'll see on the graph on the right that with the introduction of the vaccine equity metric, the gap in vaccination rates between the lowest and highest HPI quartile communities had narrowed significantly and continued to do so through April. However, in recent weeks, as you look at the far right of the graph, you will see that the gap is starting to widen again. However, disparities in vaccination rates remain lower than they were in the beginning of the graph. You see that this is something that we need to be cautious about and double our efforts to make sure that we are reaching those that are having the highest impact and are in the lowest quartiles. Next slide, please. I'd now like to introduce our panelists for today, and to set the stage for today's discussion, let me introduce our speakers. I'm very pleased that we have this august panel. For today's discussion, we've convened experts and policymakers in the field from the White House, from North Carolina, California, and Minnesota to share perspectives on how to achieve equitable equitable distribution of COVID-19 vaccines, and how we can build stronger and lasting relationships between communities and public health in preparation for the next public health emergency. Next slide. I'm very pleased that Dr. Bashara Shukair is currently responsible for overseeing the national vaccination efforts under the Biden-Harris administration. He has been named White House COVID-19 vaccinations coordinator and focuses on coordinating the timely, safe, and equitable delivery of COVID-19 vaccinations for the US population. He works in close partnership with relevant federal departments and agencies, as well as state and local authorities. He is joining us today from a pre-recorded video message to share updates on the national vaccine rollout.
Hi, my name is Bashara Shukair, and I serve as the White House Vaccinations Coordinator. Thank you so much for inviting me to share with you some of the progress on how we've been doing when it comes to the national vaccination effort. Our national vaccination strategies really has two key components. One, we wanted to make sure that we're vaccinating as many people as we can, as fast as we can. And two, we wanted to make sure that we're doing it in the most equitable fashion possible. So when you look at our overall vaccination strategies, it really boils down to three key components. One, we wanted more supply of the vaccine. Two, we wanted to have more vaccinators. And three, we wanted to have more places where people can get vaccinated. So let's take each one of those apart. On the vaccine supply front, we continue to make more and more vaccine available across the country. Back in January, we were making available 8.6 million doses of vaccine per week. Now we're averaging about 28 million doses of vaccine that are being made available across the country and across all of our channels every week. That's more than 3 times more vaccine supply. And actually, when you look at the last 5 weeks, we've made available almost 150 million doses of vaccine for states, tribes, territories, federal retail pharmacy, and the community health center program. So supply continues to improve across the country. The second part of the strategy was about vaccinators. And early on, we've made changes to our PrEP Act to allow more professionals to play the role of vaccinators across the country. That includes pharmacists and podiatrists and dentists and dental hygienists, medical students, and others. We've also made federal personnel available across the country to support vaccination efforts, either as vaccinators or supporting the logistical efforts of running community vaccination centers, including the National Guard. Thousands of National Guards across the country are supporting vaccination effort. The third part of the strategy was about ensuring that we have more places for people to get vaccinated. And that started with making available $4.7 billion to states, tribes, and territories to support community vaccination centers. FEMA has also, in partnership with states, stood up 39 community vaccination centers across the country. We've also activated a federal retail pharmacy program where we've partnered with 21 pharmacy chains, and we've made the vaccines available in more than 36,000 retail pharmacy clinics. And we've also opened a channel of vaccinations through community health centers. We've also activated mobile clinics, and that's in addition to the doses of vaccine that were going to states, tribes, and territories that were made available to other health systems and others across the country. And what we're seeing is great progress. So far, more than 56% of adults in this country have gotten at least one shot. 40% of adults are fully vaccinated. And when you look at seniors, 65 plus, 82% of seniors have gotten at least one shot, and 70% of seniors are now fully vaccinated. And when you look at deaths and hospitalization from COVID-19, the majority, over 80% of deaths from COVID-19 hit the 65 plus community. And now that all those folks are getting vaccinated, what we're seeing is 80% reduction in deaths and 70% reduction in hospitalization for 65 plus in this country. Really great progress, and I'm really proud of the progress we've made. The second part that I wanted to touch on today is really our focus on equity. From day one, equity was at the center of our strategy. Everything we do it with an equity lens. And that was important because a lot of people were asking, how would you be able to get the speed of vaccination with equity? The reality is we had to get both. So let me start in giving you some examples of how we've invested in making sure that equity continues to be at the center of our vaccination effort. Very early on, we focused on making sure that vaccine is available through community health centers. Across the country, there's about 1,385 community health centers, and they serve about 30 million people, 2/3 of whom are people of color, and 60% or so are living at or below the federal poverty level. Over the last few weeks, we've onboarded hundreds and hundreds of these community health centers. As a matter of fact, more than 700 of them with over 2,000 sites. And we've delivered more than 5 million doses of vaccines through these channels. And for the vaccines that's being administered through this channel, more than 70% is going to people of color. Also, when you think about our FEMA-run community vaccination centers, the 39 of those that we've stood up across the country, every one of them is in community that's been disproportionately impacted by the pandemic, in community with high social vulnerability index. And about 60% of doses administered through these FEMA-run community vaccination centers are going also to people of color. When you look at the federal retail pharmacy program with 36,000 locations across the country, more than 40% of these locations are also in communities with high social vulnerability index. So access continues to be an important part of how we're addressing inequity in this country when it comes to the vaccines. And we've also made available resources to support communities across the country in addressing equity when it comes to vaccine confidence. We've made more than $7 billion available to community health centers across the country to improve access to the vaccine, improve treatment for COVID-19, as well as capabilities to support their patients. We've made $4 billion as a result of the American Rescue Plan available to the Indian country. We've also made resources available to support community-based organizations, $3 billion through the CDC, to support these community-based organizations to build vaccine programs, including access to the vaccine, as well as building the confidence in the vaccine. And lots of other work around equity, including making sure that more and more states are reporting on race and ethnicity data so we can have a better look into what's happening when it comes to closing inequities when it comes to vaccinations. Lots of work on equity. It's going to continue to be at the epicenter of our strategy. And finally, I want to just spend a couple of minutes just talk about vaccine confidence, and particularly in healthcare workers who have chosen not yet to get vaccinated. We know from surveys through Kaiser Family Foundation that there's still people in the healthcare field who decided to wait and not get vaccinated. And we know that percentage varies between the place where you work, whether you're working in a long-term care facility or in a doctor's office, those percentages are different. We also know that the reason why most of these folks are not getting vaccinated yet is they're still in the wait and see category. They're concerned about side effects, long-term effect, and they want to talk to other people. That's why it's really important that we continue to engage our healthcare workforce in conversations, preferably one-on-one with their peers, the peers that they trust, to make sure that their questions get answered so that they can get comfortable getting vaccinated. We've seen when it comes to vaccine confidence across all parts of the country that vaccine confidence is going up, and it's going up mostly because people are seeing other people getting vaccinated. People are talking to other people getting vaccinated. And that's important also for healthcare workers. So let's make sure that we continue to allow our healthcare community to have that conversation one-on-one with people they trust so we can get more and more people in the healthcare field getting vaccinated. But also keep in mind that the overwhelming majority of people in the healthcare space have gotten vaccinated or in the process of getting vaccinated or want to get vaccinated. So we'd want to make sure that we're celebrating that and we're giving people who still have questions the opportunity to have their questions answered. Now, also when it comes to vaccine confidence, we've launched the Community Core effort a few weeks ago. And that's a network now of thousands and thousands of individuals and organizations that are standing up to support building vaccine confidence in their communities, within their networks, with their friends and family and neighbors. And that's an important part because we know from research that people trust people they know. So for these community core members, what we're doing is we're arming them with material from the CDC, with facts about the vaccine, facts about the safety of the vaccine, frequently asked questions. We're arming them with sample tweets and sample posts on their social media so that they have all the information they need to be able to disseminate this information to their networks and to people they know and they work with. And that's an important part of this effort. So overall, I am tremendously proud of the progress that we've made as a country. I am in awe at how this country came together where we are today when it comes to vaccinations, and we still have a long way to go. So I want to take this moment to thank everybody for all the work that you've done and making sure that we're not letting our guard down. We're continuing to work equally as hard to get the rest of the country vaccinated so we can finally put this pandemic behind us. Thank you so much for having me here.
Well, now that we have heard about the national vaccination strategy from Dr. Shukar, Let me introduce the speakers who will share their experiences at the state and local levels, many of whom have worked very closely with Dr. Shukair in the vaccination strategy that he outlined. As a note, we had one additional speaker today who cannot make it, and that's North Carolina Representative and Pastor James Galliard, who is in an emergency legislative session. We will share his perspectives in the Q&A document that will be shared in the next few weeks. So you'll have an opportunity to hear his presentation that he would have shared with us today, but unfortunately he can't be here live. I'd next like to introduce Dr. Jeffrey Reynoso. Jeffrey is the Executive Director of the Latino Coalition for a Healthy California, LCHC, the state's leading policy organization advocating for health equity of the Latinx community. He is responsible for strategic leadership and external relations, fundraising and financial management, organizational development of the staff and board, and delivering on policy, advocacy, and programmatic initiatives. Prior to this role, Dr. Reynoso worked at Kaiser Permanente as a doctoral fellow, designing innovative programs to address food insecurity in the Southern California region. We're pleased to have Jeffrey join us today. Our next slide on our next speaker is Senator Mary Kunesh. Mary was first elected to the Minnesota House of Representatives in 2016, serving for 2 terms before coming to the Senate in 2021. She currently represents Senate District 41, which covers the communities of St. Anthony Village, New Brighton, Hilltop, Columbia Heights, Fridley, and a bit of Spring Lake Park. Senator Kunesh was born in St. Paul and raised in Sartell, Minnesota. Her mother is an enrolled member of the Standing Rock Sioux tribe, and her father is a former St. Cloud city attorney, and later Assistant Stearns County attorney. Senator Kunesh currently serves on the Redistricting Committee, E12 Committee, and is the Democratic Farmer Labor Party. She leads in the Mining and Forestry Committee as well. We're very pleased to have Senator Kunesh with us as well. So now that we've heard about the federal vaccination plan, let's discuss how our speakers who are here with us today have been dealing with the issue of vaccine concerns and hesitancy, if we use that term, and how they have been rolling out vaccines in their states. Jeffrey, how have the communities that you serve been affected by the pandemic, and how has the vaccine rollout been going amongst these communities?
Great. Good morning. Good afternoon, everyone. Thanks, Mary, for the invitation, PHI and Impact. So a couple of things here, and I bring to this perspective not only my role at LCHC, but also member of our state's Vaccine Community Advisory Committee. For the Latino community, I think it's really important to think about the context pre the pandemic. Pre the pandemic, Latinos, particularly in California, over 50% were uninsured, primarily due to immigration status. 37% of the state's workforce are Latinx. Of those, 55% are essential workers. And Latinos are more likely to live in multi-generational crowded housing. So really the conditions were set up prior to the pandemic for a virus like COVID-19 to really take advantage of how we patterned our society in this inequitable manner. In addition to that, we have to think about where we were in March, April of 2020. We were starting a really politicized season at a national level. For immigrant communities in particular, we were under attack for 4 years under the prior federal administration, particularly around the public charge policy. So this policy tried to expand the public charge test, to expand the amount of federal benefits that would restrict immigrants to proceed in their green card holder status. And so what this created was a chilling effect in immigrant communities, a lot of mistrust of not only healthcare systems, but government generally. And so that's kind of what was undergirding the pandemic when it started. For Latinos, no surprise when we look at the figures and how the COVID-19 impacted our community. So in California, Latinos represent about 39 or 40% of 40 million residents. Of those that we have data for COVID-19 cases, we represent 55% of cases. And in terms of deaths, this number varies depending on the data set, but nearly 50% of all deaths. So that's 3 times that of the lowest impacted group. When we look at vaccines, the vaccine rollout, again, has been a challenge. It's been kind of a bumpy road, and we'll share a little bit about some of the innovations and policy decisions the state has made to narrow the gap. Currently today, 25% of those that have received the COVID-19 vaccine are Latinx, far below our share of 39-40% of the population. And one of the reasons for that is we are a younger population on average. Some of the early decisions that were made, which made sense from a health system perspective. So we know that those that were hospitalized and ultimately had the most severe cases of COVID-19 were in that senior age bracket. But within the state of California, among seniors, Latinos only represent around 8% of the population. So by making the decision to have the vaccine eligible by age, it really created an inequity in the system. So we really pushed the state to really think about essential workers as a priority as we were in the phase 1B in our allocation rollout. Thankfully, the state did come through, and there were 3 categories of essential workers that were prioritized in the state of California. These were food and ag workers with a priority towards farm workers, those in the education sector, and emergency services. We would have liked to see a stronger emphasis on essential workers and workforce. And that's kind of how things rolled out. So a lot of challenges, a lot of also opportunities. You mentioned, Mary, earlier that the state decided to move forward with the allocation framework of what we call the health equity metric. And what this did by providing an allocation of those 400 highest impact zip codes around social economic determinants of health and allocating vaccines, what it did, it nearly doubled the allotment to those zip codes where we see a large percentage of low-income communities of color. So in California, these are the Central Valley counties, which are inland areas of the state, the Inland Empire in Southern California, and some rural underserved zip codes within LA County. And so we saw a reduction in inequity, but we see that figure 25% so far of those vaccinated are Latino. We still have a long ways to go.
Thank you, Jeffrey. Mary, I'm going to ask you to describe the community that you serve and share some of the background on how the Minnesota legislature worked with local and tribal government to develop their COVID vaccine distribution strategy.
Oh, sure. And thank you for inviting me to be here this afternoon, and to our listeners for checking in to hear about this. So I represent communities that surround the Minneapolis-St. Paul area, sort of a first ring suburbs, and it's very diverse. I would say approximately 55% of the folks that I represent are either new Americans or unique cultural communities. We have the largest Tibetan community here in Minnesota. And so sometimes when we have these sort of issues, it's interesting to find ways to communicate and connect with those communities. So we in Minnesota really took sort of a regional healthcare look, utilizing what we called hubs. Within those regional healthcare coalition, we found providers and allocated vaccines to those hubs. So think of a wheel with a hub in the middle, and utilized our public health facilities. We created allocations to our federal organizations such as the Veterans Affairs, Bureau of Prisons, Department of Defense, and also worked specifically with our Indian Health Services to allocate vaccines to our tribal nations around the state. And we have 11 reservations here in Minnesota. And if you know anything about the history of our attention to the healthcare of our Native folks here in the United States, it's always been abysmal. My grandfather was born in Standing Rock, and he and my mother were enrolled members. And so I understand very well the vaccine reluctance, or the reluctance to participate in some of these rollouts that we've had, given the historic trauma to Native communities that were often used and as guinea pigs in different medical practices and feelings around that. And so we had a lot of discussion with our tribal folks around the vaccine and their reluctance. I have to say, probably one of the biggest impetus to get vaccines was to preserve the elders. We lost so much of our language, so much of our culture through the genocide, through the foster care system and the boarding school system, that we just, there was a lot of lack of trust in anything governmental. And so one of the things that we had to do was to encourage and let the communities know that this was something that they could trust. And I think what really motivated communities was to preserve their elders, so that we had those few language speakers and cultural practicers left for my generation and the next generation. And so we were very intentional about getting vaccines to those communities and utilizing services that were already trustworthy to those communities. We did a lot of work around communication. So as a senator in the Minnesota Senate, 4 years in the House, I'm one of the founding members of a caucus. We call ourselves the Posse Caucus, People of Color Indigenous, so POCI. And we have been a force to reckon with in the last 4 years, especially as more folks of color have joined our legislature, in insisting and demanding practices that haven't happened in the past, and especially around communication. So we sought out faith leaders and churches. We sought out community leaders. Our legislators themselves created videos and included in their correspondence the necessity for this. We have large Hmong population, large Somali population on top of our Latinx and our Black and our Native American folks. And so we really were intentional about building the trust for this vaccine, because initially there was a lot of distrust within our new Americans, and did it in, I think, in just a really, really well thought out way. We also, our state government of Minnesota also supports a radio network called Ampers, and that reaches out into rural Minnesota quite a bit. The small radio stations, reservation stations. We have a radio program called Native Roots. And so we were very, again, intentional about utilizing those resources to get the message out to the community members. And so we were able to broadcast in all these different languages from folks that were trustworthy. And I think that helped build up some of the participation. I know it did help quite a bit. And so very, very intentional about how we rolled it all out.
Thank you so much, Mary. And you really touched on a number of issues that we had questions from our audience in advance of today's session. We got some web questions, so I'm going to kind of weave those in. And Jeffrey, if you could build off of the communications and trust theme that Mary so eloquently described from both a legislative and a community perspective, and talk about some of the messaging that LCHC has been utilizing in the Latino community in California. What are some of the things, and how have you built that into your messaging? And are there other factors that, you know, trusted media that you found successful? Thanks.
Yeah, so in the early days of the pandemic, we leveraged our social media platform, which we call our air game across the state, to start sharing some rapid response, basically information around COVID-19, around prevention. And we were also polling our audience. And what we were hearing was a lot of the initial information that our communities were wanting to know more about were around the economic stimulus packages at a federal level, at a state level in Sacramento, housing assistance, food assistance. And so one of the things that we try to intentionally do with our communications is an understanding that individuals don't live single issue lives, and you really have to be intersectional with the types of information that you're sharing. So they may come to us with information around how to access an economic stimulus, or questions around who's eligible depending on immigration status for these different programs. And then we build in, you know, that vaccine information or that COVID-19 prevention information. So the way that what we've learned from our communications work through what we call Facebook Live or Facebook Live COVID-19 Pláticas or conversations is we take a three-pronged approach. So it's the right messages through the right messengers, through the right message channels, the right messages. So similar to Mary, Latinos are very family oriented, and the messages that resonate more are those around, you know, taking care of yourself, getting the vaccine to get back to your, you know, to get back and be around your family. Go back to the carne asada or the quinceañera, the baby shower, right? All of these messages rank, and we see this in polling data from Kaiser Family Foundation. Latinos or Hispanic Americans were the most likely to resonate with messages around family and culture. So those are the right messages. Now, with the right messengers, you know, we as a Latino community, we're not a monolith. We have elders that certain types of messages resonate more with elders, with kind of my age bracket, the millennial age bracket. Different types of messages resonate, and so we have to be intentional about breaking down the intersectionalities within our communities, also looking at different identities. Immigration status is an identity that we try to be cognizant of, LGBTQ status. All of these intersecting identities also matter, and who is the messenger. And so what we did was we partnered with youth for the millennial age bracket, and we also partnered with promotoras for kind of that older age bracket. Promotoras are community health workers, and what they do is they deliver the message. They're already a trusted messenger because they're reflective of the communities that we're trying to reach. And then finally, the right communications channels. So for older Latino adults and seniors, they're more likely to be on Facebook or WhatsApp. For younger millennial or working age adults, we find that Instagram is a more effective strategy. And so we create different communications campaigns across those social media channels. We also did some work internally around ensuring that we also partner with radio stations. With a state like California, we hold one audience through our Facebook and Instagram platforms, but radio stations and partnering with radio stations to get the word out, we see a marginal increase, actually a significant increase in the viewership for a particular Facebook Live Plática after we put a radio spot. And so, it's a learning process. We're iterating every week, but I think the take home point here is that government can't do it alone. They need to partner with community-based organizations, trusted organizations that have those relationships on the ground and are able to communicate, the science information and all of these very confusing guidelines around eligibility and access points to the community through trusted messengers.
Jeffrey, one thing you didn't explicitly touch on, but I know it was woven into some of the strategies, is literacy issues. Could you just mention a couple of specific examples? And I know we could talk about communications and trust all day, but then I want to move to a couple other topics.
Yeah, I noticed that in the chat box, the health literacy or just literacy issue generally, it continues to be a challenge, particularly when you think about immigrant communities and Latinos. By the way, Spanish is one language; it is a dominant language. When we look at specific subgroups within the Latinx community, we do have, particularly around our farm worker populations, several indigenous languages that are predominant in California. And so we worked with the state through the Office of Emergency Services, the Listos California campaign, to develop messaging through audio files. So being able to share these through WhatsApp, through text messages in indigenous languages has been proven very effective. In the work that we do with promotoras in particular, and having them be the conduits and the cultural brokers to the community, we use what is called a popular education model. So this is a model where the promotoras meet the community where they're at, understand their literacy levels, and are able to share information. And oftentimes it's not, a CDC or a state health department short message, but it's really a long conversation, almost like sitting in a living room with a good friend or a family member. And it's a two-way conversation. And that's why the Facebook Live Plática conversations have been particularly effective, because it is a two-way communication between the community out in the virtual space and the promotoras themselves. Now, I will flag that we still have a challenge of the digital divide. So we are reaching those that have access to broadband or a cell phone and are able to tune in. But we have some additional challenges, and that's why it's so critical to support those community-based partners, community health centers that can be on the ground in communities and provide that face-to-face interaction.
Thank you. Mary, I want you to be thinking, if you have one last comment on communications, we'll wrap that up at the end. But I want to give both of you just a high level, what policy measures do you think have been most important that have been prioritized at the state level to help ensure equitable vaccine distribution? Mary, let me start with you.
Sure, I would say that communication from the get-go was very, very important. And we worked hard to ensure that so much of the information was translated verbally and audibly to all of our different language speakers, both on the government, the state website, and the information that was going out. And so, that was something that our state had not done to the extent that it has since the virus started. So the website has so much information translated, PDFs and information about how to get your vaccine and where to go and who to contact with questions. And I feel like that was that was really explicit, as well as, graphics and quick blurbs that we could tweet. And just as Jeffrey mentioned, the use of social media was extremely a high priority. And I feel like it worked out really, really well.
Jeffrey, anything to add from your perspective in California that was a high priority? I think besides the HPI, health equity metric, which I think was really important.
Yeah, I'll mention that I think the state of California, I think building off of the investments in the government and CBO infrastructure from the census, from public charge providers, they provided a multi-million-dollar investment in nearly 200 CBOs. We were fortunate to be one of those CBOs, and investing in those partnerships and creating those linkages between local health departments, health systems, community health centers. So basically connecting the vaccinators and the vaccine sites with those CBOs so that we could share, through informal channels, through the ways that we know how to reach our communities. And it varies by communities. For some of us, it may be a tweet or a Facebook post. For others, it may be a WhatsApp group, and for others, it may be a hotline or a robocall number. And so the ability to partner between government and CBOs was not only important for the vaccine, but thinking about future pandemics, thinking about future natural disasters. I think it's really important to continue strengthening that network of CBO and government because it's not going to be the last, public health emergency that we're going to encounter as a nation and here as a state.
I have to add a shout out to the philanthropies in California that have come together and created a pooled fund. Public Health Institute has been supporting that effort, which is providing those more flexible resources to the community-based organizations. We've only got a short time left. I want to have really quick responses. First, we have to talk about data. It's so critical in this pandemic. And if you could just highlight, Mary, one of the challenges of consolidating data from different sources in your state and talking a little bit about how the health systems and localities have been working together to get that data right.
Sure. We were, again, working very intentionally on collecting that data and making sure that we were interpreting the data accurately so we knew where cases were coming from and where we needed to concentrate vaccines. And so once again, I would say that our Minnesota and our public health department did a very good job of updating the website that we have daily. As legislators, we had initially daily conferences with our public health commissioner and the governor, very communicative that we could share with others. And I have to say that if you look back into the progress of this through COVID, that data was kept at very minute information and at levels so that we all knew exactly what was happening within our state, where we needed to shut down, tighter.
Hyper-local data, right?
Yeah, very much, very local. Yep.
Jeffrey, I know that you and LCHC were involved in a COVID-19 farm worker study. Could you just briefly share some of those findings and why that data was so important?
Yeah, absolutely. So the farm worker study was a collaboration between academia, UC Davis, and several CBOs that we work with. The Farm Worker Care Coalition, one of our program managers is a member of in Northern San Diego County, the Líderes Campesinos in the Central Valley, the California Rural Legal Assistance Foundation. And I think it showed a lot of findings that weren't surprising, I think, for those of us that work directly with farm worker populations and the community. Some of the findings were around the social determinants. So, for example, around work, there were uneven protections depending on the specific employer, uneven enforcement of employment laws, and particularly around supporting farm workers with PPE, issues of job and wage loss, particularly for women and Latinas in particular. When we see the data for farm workers and other essential workers, women and Latinas were hit the hardest. What we found from the study is many of them had kids that were now going to virtual school and had to take a step back to support their children in school. Households, we're seeing kind of one of the findings that I think we have to think about from a health system and a public health perspective. There's a lot of heightened stress and anxiety on top of the existing stress and anxiety post-COVID. Mental health issues are going to be with us for some time, and we have to start preparing for, I think what might be a tsunami of mental health and depression and anxiety among Latino and other communities. And then finally around health, there was a lot of uncertainty around where to get testing and where to access care. One of the things that I'll share more on the information front with Latino communities on the vaccine, and we've heard this time and time again, not only from the farm worker study, but through our polling with community members, is when you go to a vaccine site and you ask for an identification, and when you ask for an insurance card, even though we know the vaccine is available regardless of whether you're insured, whether you have health coverage, and whether you're documented or not, it does provide a barrier for a community. And so what we've been doing in our messaging is kind of walking through the community what to expect when they go to a vaccine site and the different types of identification that they can show to just kind of match their name to their appointment, and also that they don't need to show a vaccine card, and those who are uninsured are still entitled to a vaccine. So overcoming those information barriers continues to be a challenge.
Thank you so much. I know we could go on for hours. Unfortunately, the time allotted to this webinar is ending all too soon. We haven't gotten to all of our topics. If I could have slide 17, we had talked about what were some of the key messages that we hope people took away. And I think that we've touched on each of these key messages. I think we might have to do another forum with each of you. And I know there were some questions in the chat around the faith community. And I think Reverend Galliard would be well placed to be able to answer that. So for those of you who are on today's call and we didn't get to your questions, we do send them out afterwards. And I believe that we may try to do a reprise to today's session. So these are the key takeaways: the importance of engaging local partnerships, including medical and policy communities, obviously campaigns, communication campaigns, collecting data, making sure that data is hyperlocal and visible so that people can utilize it, and having the legislatures work with community stakeholders so that the long-term policy measures that can improve health equity and prepare for future public health emergencies is top of mind and top of action. If I could have the last slide. We did put together a few resources for people who are on this call. We want to share this with you, and you'll be able to download this later. So I want to thank everyone who was on the call, and particularly the panelists and Dr. Shuker. And I wish you all a good day and hope that you'll join us in future webinars. Thank you all so much.